Thank you, Professor Shabi. Hello, everyone. Today, Saudi International Virtual University has the honor to host Professor Shabi Zaidi, the founding chancellor, and Professor Susan Jamieson, Director of Health Professions Education Program, University of Glasgow, Scotland, UK. Today, we are going to talk about faculty development for medical or clinical education. If you want to know more about Susan, Professor Susan Jamieson is Prof of Professions Education at the University of Glasgow, Scotland, UK. Her original background was in cancer research, but from the mid-90s, she became increasingly involved in medical education, initially as a lecturer and lab leader, then in curriculum management, first as director for year one, and ultimately as deputy head of the UG Medical School at Glasgow. For 10 years, she ran the medical schools training program for PBL facilitators, delivered teaching skills workshops for social educators, and participated in peer observation of teaching. From 2014 to 2016, she represented Glasgow Medical School in the national group responsible for implementing the General Medical Council's Recognition of Trainers initiative in Scotland. From 2015, she led the development of the University of Glasgow's fully online part-time master's program in health professions education, which currently has about 100 students from different parts of the globe. She has also led the development of online resources for local educators and most recently, micro-credential in teaching healthcare professionals. She enrolls students in medical educational topics. Welcome, Susan, to this webinar, and we are ready to hear your speech. Thank you.
Thank you. Thank you very much for the invitation to speak. Thanks to all of you who are here to listen to my talk. I hope it's of interest to you. I look forward to taking any questions. If you want to post any questions in the chat, I may see them as I'm going along, but it can be quite difficult to keep an eye to those. And if need be, I'll pick them up at the end. My topic is faculty development for medical education. And really what I mean by that is faculty development for medical educators, who in turn will help progress the discipline of medical education and ultimately the discipline of medicine through their work. There are several intended learning outcomes for today. Oops, sorry, just have to. I hope that by the end of this webinar, you'll be able to explain the need for faculty development for medical education, outline principles for faculty development, and identify examples of where these have been applied. And I'll offer examples to you, but I also hope that you'll be able to identify examples that you've used yourself or you've experienced yourself. I also hope you'll be able to identify challenges and debates in faculty development. And I've not said that we'll find solutions, but perhaps that's something that will come into our conversation at the end. I think it's a good point to start with a definition. So this is a definition from Professor Yvonne Steinert, who's one of the key writers and researchers in the field. And she defines faculty development as that referring to all activities health professionals pursue to improve their knowledge, skills, and behaviours as teachers and educators, and leaders and managers and researchers and scholars in both individual and group settings. And I've highlighted the part in blue because that's my focus for today. It's about our role as teachers and educators, and we'll briefly touch on other aspects of this definition later. So to deal with the first outcome that I suggested you should be able to take away by the end of this webinar, why is there a need for faculty development for medical education? Yvonne Steinert has written a book in 2014 where she distills some ideas about this, although there are others who write, and especially the first one here, there are lots of people in the UK that are very interested in this first reason. But the first one is professionalisation of medical educators' teaching practice. And it stands to reason that that potentially benefits their learners, so their students or their postgraduate trainees. And ultimately, it will hopefully benefit the patients that those learners interact with in future. Faculty development can provide a shared conceptual framework and also an introduction to community of practice. And it's capable of facilitating curricular change, organisational change, and enhancing organisational capacity. And I'm going to pick up on some of these ideas as I go along, and I think they're all reasonably self-explanatory, except perhaps for number 2. So I have a couple more slides to elaborate on number 2. So just to say something about the conceptual framework. The conceptual framework that is probably held quite widely, not just in medical education, but in education more generally in the higher education sector, includes concepts such as those shown in my slide. So about learning theories, we're very keen on the idea of constructivism and also socio-constructivism. And you may know that constructivism is essentially about building on existing knowledge, and that's one view about how we learn. Socio-constructivism is about learning through social interaction, i.e. discourse. A second concept is that of learner-centeredness, where we are focused very much on what the student or the trainee, or in our case, the staff who come along to faculty development sessions, what they are interested in learning, what they need to learn, and also in order to do their job. Then we have principles of active learning. So that's where you may want to, even if you have I just saw a message in the chat there from Shwali. So, and that's actually a good prompt to me to say, one of the ways of active learning is achievable even through a lecture such as this. And if you feel like it, why don't you use the chat to just add how you use active learning even in your lectures. So by that, I mean things such as posing questions, getting people to work on projects, that kind of thing. Not necessarily practical sessions, but even during lectures, we can use active learning. We also use reflective learning. You're very familiar, I'm sure, with the idea of reflective practice, and essentially you're learning about your practice through reflective learning. So thinking about some experience, probably applying a framework such as Gibbs to facilitate your reflection, and then identifying what could be done differently moving forward. Another concept that is increasingly recognised in graduate education, not just in higher education for those who are not yet graduated, is the idea about transferable or generic skills, the importance of these. And one you might not be so familiar with is sustainable assessment. And essentially that means assessment for lifelong learning. So things like self-assessment and also reflection. You've noticed probably that I've put some terms in blue, and these are ones that I think you might not be quite so familiar with, because I obviously don't know very much about you as an audience. But if there's anything I mentioned that you're not sure about, then feel free to post in the chat or feel free to ask me at the end. I said I would say a little bit about also the community of practice. So this is another function of faculty development. It can introduce individuals to a community of practice. And the concept of the community of practice is credited to Lavey and Wenger. And I've put a couple of their key citations there, and the references are in my last slide. But also, there is a good chapter by Kaufman in the book called Understanding Medical Education. Excuse me while I take a drink. Thank you. And he brings together ideas about different learning theories, and it's very accessible, and he describes the community of practice. And some of the concepts in community of practice include that we have a shared domain of interest or competence, and for us that is medical education. There is a community, and that community can be in person or virtual. That the community members share some aspect of practice, and we are talking about teaching practice. And another concept that's important is legitimate peripheral participation. And what this means is that newcomers can participate through doing real work of the community. And if we think, for example, about how we invite medical students to do peer teaching, we might consider that legitimate peripheral participation in the community of practice of medical educators. So having set the scene about hopefully the purposes of faculty development, the second ILO is about principles of faculty development. And I haven't, I think there's no definitive, this is how you must do it. But there's a very good resource, which is this book by Yvonne Steinert. And I've distilled some principles from that, from some of the key things that she writes about. So in this slide, I've summarized these as faculty development for medical educators is not just about teaching skills. It's also about generic skills and about their professional identity as medical educators. A key form of learning is experiential learning, so what they have experienced, and also taking what they learn from faculty development sessions and applying it to their new experiences. Key to successful faculty development are things such as peer coaching, peer observation, and mentorship. Yvonne Steiner advocates that we should use effective workshops, and we might come back to that later. How do we know they're effective? She advocates longitudinal skills development over time. She also advocates online faculty development, but of course her book was written before the COVID pandemic, and we're probably very much more familiar with online faculty development now. And she advocates scholarship and research into faculty development. So hopefully, having set the scene about why we do faculty development for medical educators and some of the principles of it, and I want to switch tack and take you through my experience as a faculty developer and hopefully illustrate some of these ideas and perhaps give you some things you'd like to follow up with me. So as Shoali kindly said at the beginning, I started my journey as a faculty developer by running the PBL Facilitator Training Programme at the University of Glasgow Medical School. And I ran this for 10 years, and it was just a small part of my job, but it was, I think, and hope quite an important part of my job. And the way I personally approach faculty development is like a teaching session. So the staff who come along to the sessions I regard as my learners. So I put in practice something like this cycle here, and I hope you're familiar with the teaching cycle or a diagram similar to this. And we usually start at the needs analysis part. So just to show you how I applied this for the PBL facilitator training, the needs analysis is at the level of the organisation often when you're a faculty developer, but also at the level of the people who are coming to your sessions. So a big important need was that the previous trainer had left. So somebody needed to step into her shoes. We also had a turnover of trained facilitators. We needed, at the time, we had 30 PBL sessions running every day, 4 days of the week. And people would do the PBL facilitation for maybe a couple of years, and then they would move on and do other things. So we constantly had to replenish the pool. And for the individual staff members, faculty who came along to the training programme, we wanted to enhance their individual educator skills. The planning was fairly straightforward for me because I was actually stepping into a programme that a peer had delivered, although I did make some changes to it. But when you're planning any session, as you'll know, you think about the outcomes that you want your attendees, your learners, your faculty to achieve. Any theory, in this case, explaining to them about the theory behind PBL. And you think about things like the venue and the resources. And because this training programme was fairly fundamental to the working of the curriculum, I didn't fortunately have any issues there, and I had good admin support and so on. The facilitating learning, that was about the activities offered, which I'll describe in a minute, but also the skills, trying to model what I was talking about. So for example, using open questions, probing questions, summarising what people had said. Then there was no assessment because this wasn't for students, so there was no formal assessment, but we did build in peer observation of facilitation skills. And then the programme was evaluated by the kind of typical questionnaire, but also indirectly during the sessions of the programme, we were able to get feedback from participants. The actual training programme was 3 different aspects plus a follow-up. So the first part was a 2.5-hour small group session in the medical school at Glasgow, which is shown in this photo here on the right. And we really talked about principles of PBL and what people felt about it and how with their comfort zone it was, that kind of thing. And then we arranged, with the support of the administrator, I arranged for each trainee to be matched with an experienced facilitator who role modelled facilitation skills for them. And they usually found that very, very beneficial, and there was good feedback about that. And then in another day, we brought them back and we had another 2.5-hour session where they reflected on their experiences. And they had all of the attendees had been with different facilitators, so they saw slight differences in style. And what we achieved at the end of that session was a shared understanding of what good facilitation looks like, and also hints and tips about things like managing group dynamics. We also build in a requirement that there is mandatory peer observation of teaching. So in this case of facilitation skills, at least once every 2 years, but often new trainees wanted feedback sooner. So I would offer that, or one of my senior colleagues would also offer that. And I think the key thing that I think were really key about this being successful and well evaluated, because it was that I tried to explain the relevant theory, principles and rationale, but not do too much, because I think that can turn people off. Role modelling was important, both myself and also the PBL facilitators, the experienced ones. Peer observation is really helpful, both for the person who's observing, but for the person who's being observed, because it makes them often think about their own practice. Reflection, and that was done collectively in the third session. Feedback to the trainees on their PBL facilitation skills. And this was also a holistic offering, so it wasn't just the training programme. We provided lots of resources, for example, guides on how to facilitate. Back Forum was a website that I set up, and it had things like research articles if they were interested in exploring further. And then we had regular briefings and debriefings with the trainees. And although these were focused on the actual content of the curriculum, there was also the space for people to share issues they were having with facilitation. So to move on, my next foray into faculty development was really very different, and I only have a couple of slides about this. And whereas the previous experience was like 10 years of a very structured programme, this was a week, just 1 week, but a very intense week where I went with a team. We were sponsored by FAMER. I think some of you will be familiar with FAMER. And we went to Ethiopia and delivered workshops and curriculum development. And I think what I wanted to say about this was that this highlighted to me the need to be very sensitive to the local context. So one has to be very aware of the venue and any issues that might be there. Excuse me. I'm very sorry, I'm drinking out of the bottle, but I couldn't find a cup, just typical. But anyway, the venue that we were delivering in was a brand new medical school, shown in my picture here. But resources were more of an issue, because we'd been warned that because the school was new and it wasn't fully fitted out, then we might have issues, for example, with the electricity. And in fact, we had issues with the water supply and everything. But we prepared as well as we could for that. And we took, as you can see down here, plenty of paper and pens. And we really relied on our skills, if you like, learned the old way. We couldn't use PowerPoint for quite a lot of the time. And we really emphasised getting people to tell us what their concerns were, what their understanding was, to hear from us about how they could do things differently, and then to discuss those suggestions. And what we were also concerned about was hierarchies. We have hierarchies in our own context. It seemed to us that these were more obvious in a different context, but that might have just been our increased sensitivity when we went to a different context. And our role there was to help. It was doctors, nurses and biomedical scientists, and we were aiming to help them find local solutions for local problems. And those problems had been brought about because they had been required to implement a problem-based learning curriculum that they had brought in wholesale from America, but it was suited to the system in the States, and they did not have the resources to deliver in exactly the same way that was being expected. And so they were looking for ways to deal with this. So I think the other slide that I have about this experience is just to say that this really reinforced for me that there is no one-size-fits-all approach to faculty development, and faculty developers need to take account of context. My next foray in faculty development is back in Scotland, and I was involved in developing teaching skill workshops, and I've been doing that since 2014, and these are face-to-face workshops. I don't deliver so many now. Now, there were two drivers for this. If you remember, I said we always have a needs analysis, and quite often there is a need that comes externally. And the first driver was the appointment of members of staff that we call clinical teaching fellows. These are year-long contracts, and they're nicknamed FY3 because people often do this year after the mandatory 2-year foundation programme. And the appointment of clinical teaching fellows was one response to results we'd had in the National Student Survey, the NSS. This is a questionnaire that's disseminated to all final year students in the UK, and it's really high stakes because it impacts the reputation of a course, of an institution, and it also can affect funding. So when we as a university joined the National Student Survey in 2007, the medical school got really poor ratings, which was horrifying to us, and we spent a lot of time looking into why this was so. And one of the things that students were unhappy with was the clinical teaching. And one response to this was to employ clinical teaching fellows to help organise and deliver clinical teaching. So this was about increasing organisational capacity and also professionalisation of teaching. And if you remember, these were two of the functions of faculty development that I mentioned right at the outset. And what we wanted to do was to professionalise the practice that these mostly young clinical teaching fellows delivered according to various sets of standards. I'm not going to say much about these, but you can look at them later if you're interested. But these are standards that we work to for medical education in the UK. So Advance HE is an organisation that takes to do with the quality of teaching across all of the university sector. And their most recent framework, or the most recent edition of their framework, has just been published this year. Then AOME, the Academy of Medical Educators, has standards specifically for medical, dental and veterinary educators. And then the General Medical Council, our regulator for medicine, has its own standards, its Promoting Excellence document, and these draw from the AOME standards. So we wanted to help clinical educators work to these, or begin to work to these. I said there were two drivers for the teaching skills workshops. The other one was a national one, and it was UK-wide, but each part of the UK dealt with it in its own way. And what we were trying to do was to prepare for the Recognition of Trainers initiative that was due to be implemented in 2016. Now, this had been mandated by the General Medical Council, and it was a response to feedback from medical students and trainees who were not happy with aspects of their teaching. So this is undergraduate and postgraduate. And it was about promoting organisational change, because probably in the undergraduate sector, it was reasonably fair to say that there was a lot of evaluation of teaching, feedback, and constant improvement of the teaching. But in the clinical environment, it was very much left to the individual how much they really engaged with their teaching practice, and the General Medical Council wanted to change that. In Scotland, we sought to embed professionalisation of medical education by working together. There was an organisation, in fact it still exists, but it's no longer called this name, but it was then called the Scottish Deans Medical Education Group, and I was a member of that group. Hello, Nadal. I'd just seen your comment in the chat. I was a member of that group because I was then deputy head of the medical school, and all of the heads or deputy heads and other members of the school senior management teams were part of the group. And we also had representatives from NHS Education Scotland who take to do with the organising of educational activities in the hospitals. And we put various mechanisms into place. So we had road shows where we went out to big venues and we invited local doctors in and we told them about the GMC's recognition of trainers initiative. And we tried to reassure them because people were very worried about what they saw as taking on board an extra duty and the policing, they felt like, of their teaching. We set up a website that was hosted by NES, and that again served a similar purpose. We put in place a quality assurance process, and somebody is managing to draw on the screen. I'm not quite sure how that is happening. We put in place a quality assurance process, which was to allow us to look at the evidence that doctors were going to have to submit about their training for their teaching part of their practice. And then finally, but importantly from the point of view of this presentation, we put in teaching skills development. And that's where I came in with my teaching skills workshops. I'm not quite sure how I've ended up with scores across the screen here, but apologies for that.
Can I request whoever is fiddling with the screen, please do not do that. It's disturbing all the audience and the speaker. Kindly delete these marks on the screens. Thank you.
Thank you very much for that. So I hope you can still see that, again, we use this process of the teaching cycle to think about the teaching skills workshops. And what I had to particularly pay attention to was the type of teaching role of the people who were coming along to the workshops. So some of the delegates would be clinical supervisors, some would be people who mainly lectured on the preclinical topics. So lots of different experiences of teaching. And some people had very little experience of teaching, but some people were very esteemed members of faculty, but they had never had any faculty development for their teaching skills. And some were very open to the idea, but some were not at all open. They were quite offended, in fact, at the idea that they were invited, in inverted commas, to come to this session. So we had to be very sensitive again and work with staff of all different, with all different backgrounds, all different requirements and all different views about the value of the teaching skills workshops. I won't say too much about the planning, but essentially what we were offering was hands-on active workshops where there was a lot of things to do rather than sitting, listening to talking all the time. And again, facilitation skills came into play very much. There was no formal assessment of these, but we did try to build in the kind of sustainable assessment activities, so reflection and lesson plans in the workshop that we ran about planning your teaching. And then all of our sessions always have to be evaluated, at least with a questionnaire. These were really successful. We got really good feedback. And I just see a message in the chat. Oh, thank you, Iqbal. So to continue, we put together a programme of the different sessions. We picked core topics that either were important from the point of view of keeping the students and the General Medical Council satisfied, or that people told us they wanted to learn about. So for example, we had writing MCQs, evaluation, clinical supervision. They lasted for an hour and a half to 3 hours in person in the medical school again. And to make life easier for doctors who were travelling in from the outlying hospitals, we managed to organise some catering and we organised parking permits because it's very difficult normally to park round about the medical school. Unfortunately, this didn't really take off. And although we got really good feedback on the individual sessions when people came, they couldn't and wouldn't sign up to coming to the longitudinal programme. They simply couldn't get the time, or maybe they weren't sufficiently interested. So they came to 1 or 2 workshops that they could manage to attend. And what this really reinforced for us is that working clinicians, full-time clinicians, cannot take a lot of time out to go to a different site to do their CPD, to develop their skills for teaching. And we had two main responses to this. And one of them was to set up a one-day conference. I ran the first one in the building that I'm currently sitting in just now, the Royal Infirmary. And then my colleague, Dr. Jim Boyle, who should appear in a minute, hopefully. Yes, there he is down in the corner. So Dr. Jim Boyle, he worked with me to help develop this, and he gradually took over, and he runs it now at this is the Teaching and Learning Centre in the Queen Elizabeth University Hospital, which is our biggest, newest hospital in the region. So this is a one-stop shop, if you like. People come along to this one-day session, and it's easier for them to take that time out of their schedule. The other way we went down was to go down the route of online faculty development. And there were various things that came together at this point. And I've put this slide in just really to remind me to say this, that sometimes things all come together in a certain way, and it makes it sound as if you planned everything. But I think that there was a lot of serendipity there. I had been taking care of my own faculty development. One of the things I had done was a part-time doctorate in education. So that's me in the middle, and these two ladies are my supervisors, very bright ladies, both in what they wear and also in their intellect. And I put this in here to say that I was a newcomer at some point to the theory behind teaching, learning, assessment, and so on. So I had to develop that knowledge and the skills, and then hopefully share that with people in the community round about us. And that's one way that I developed my own knowledge. But I also put this slide in to say that this really helped me to understand my students on the online programs when we developed these, because they were full-time healthcare professionals, mostly doctors, but also from other professions. And they were holding down full-time jobs and doing part-time study at the same time. So I had been there, so I could understand a lot of the issues that they would have. And I think that's quite important. So the online Masters in Health Professions Education, which is the main part of my job now, it's been established since 2015, but the year before that, I was running the face-to-face version and also developing this. And I developed it largely with these two ladies. You can see their names there, Dr. Kimmy Hooser and Dr. Yvonne Slater. And it's fully online. It's a 3-year program part-time, and it's got very nice software and all the rest of it. It's got lots of active learning, but it's asynchronous, so not in real time, so that people can access it in their own time. And I can talk more about it later if you're interested. But what I do want to say about it, go to my next slide, is the planning, thinking about the planning that went into it. And I hope by now you're clear that I think planning is really essential for faculty development offerings, whether you're offering one session or a master's program. So these are the stages of the teaching cycle again. Needs analysis, we had decided that, in fact, we've been told by participants in what my colleague used to run a face-to-face masters in person, but it was poorly attended because people couldn't often get away from the clinic. So the classes were often much smaller than invited speakers had been led to believe. So we were going down the route of asynchronous online learning materials to offer maximum flexibility to students. They wanted modular learning. The university wanted us to go down this route. So lots of small courses that people could mix and match to an extent. A degree of choice. So we have a variety of year 2 options, and we also have 2 different master's routes. And we also have different start dates, so people can come at 3 different points of the year. Then the actual planning of the learning materials, we gave a lot of time to curriculum and lesson design. We also had to think a lot about software, and I'm not an IT specialist, so I really had to rely on my learning technologist colleagues and also the general IT support, and this really was very much a team effort. And the other thing that came in for the first time here was marketing, because previously my forays into faculty development had been local needs, local to the medical school usually, or with the exception of Ethiopia, where I'd been invited to be part of a team. In this case, we were marketing this. And we were hoping that we would have our local colleagues, but also that we would have international colleagues join the programme. The actual learning, we use a learner-centred socio-constructivist approach. We have forums for peer learning, and we aim to get something that we call social presence. In fact, it's Randy Garrison that calls it social presence. And what that means is the social environment and also the social interactions that go on, for example, in the forums. We aim for a mix of theory and practical. Theory, because people do have to know why we're doing things the way we're doing it, but practical because that's what people want. They want to know, what are the tips that will make me a good teacher next week when I have to deliver a lecture to a class of medical students. Assessment, we've tried to make this sustainable, so remember, for lifelong learning, but also practical. We have things like weekly reflective posts in most of our courses, a micro-teaching assessment, which the students are just about to hand in first year, where in fact, I can talk more about that later in the Q&A if you want. Wikis, so something like Wikipedia, but the topic is maybe an assessment, a type of assessment. And then we do have structured essays. We can't quite get away from essays. And of course, we have formative feedback. That's a feature throughout. And then we evaluate everything we do. We have the ubiquitous questionnaire. We have a student rep, but we also build into the learning materials. So I'm seeing there's a question there about student evaluation of teaching. So if I may come back to that towards the end, then that would be lovely. And please remind me if I forget. I'm just trying to move. Yeah, there's the next slide. So just also, I mentioned the importance at the start of generic skills development. So Yvonne Steiner has argued that it's not just about the subject-specific skills, but it's also about generic skills. So, for example, the university offers its own skills programs, such as in academic writing. One of the things we did in the Health Professions Education Programme was a critical appraisal skills and education research strand. I run that myself. It's formative. Each semester in year one, it takes place. The students are given a paper to critique. In one semester, it's qualitative research. The next semester, quantitative. And then the third semester, mixed methods. And we have a synchronous discussion session. And my role there, I see, is trying to demystify the whole process of critical appraisal and make people feel less anxious about it, because they are very anxious about it at the start. And then they're asked to do the critical appraisal in their own time, and I provide an exemplar for them to compare against. And it is up to them whether they engage with that, but a number of them give us feedback about that they have done so and what they've learned from it. And then another example here is support for literature searching, which the college librarians provide to students who are at the dissertation stage. Okay. I think this is the last slide about this particular programme, and I just wanted to say that our philosophy is that it's quite good to have multi-professional education. It was a key decision to name our programme the Masters in Health Professions Education. We are a school of medicine, dentistry and nursing, so our faculty include people from different backgrounds, but we also hope to attract healthcare professionals from different professions. And we believe that we can learn a lot from other professions. And this italicised piece here is a quotation from one of our current students, Evangeline, and it's on our website. And just to read part of it to you, she says, "The best part of the course so far is the learning through interaction with the many different professionals that come from different multidisciplinary backgrounds and cultures." And we get this feedback quite often from students. And this is on our asynchronous forum. And we're not the only people who think this. So this quotation at the bottom is from colleagues in Edinburgh who write that they very specifically design space and structure for teachers to think and talk about education with colleagues in other disciplinary contexts. Okay. So our programme is successful. We've gone from 12 students at the outset to regularly about 100 in the programme, with some coming, new people coming and some going each semester. But it's not for everybody. Not everybody wants to commit to that amount of learning, and they don't all want to commit to that amount of fees. So we've explored other options over the time, and I'm just going to say a little bit about a couple of these. One of them is what we call HPE Bites. These are 5-minute online lessons, and there are various narrators, myself and other colleagues. Camille is instrumental in this. She's my deputy in the HPE programme. She has helped us to repurpose some of the material from the parent programme to create these 5-minute bites. For example, writing ILOs, writing MCQs. And this one, Failing to Fail, was really important to the medical school, because one of the things we were finding was that clinical supervisors, or educational supervisors rather, did not like to be the person that stopped somebody from graduating in medicine. So even if they didn't think that a medical student was as good as they could be in a placement, they did not want to fail them. And it was, the senior management were very keen to say it was important, obviously, for the patients, but it was important for the student as well to know that they actually were not quite good enough, and to put support in place for them. So that was we were trying to meet the needs not only of the people who were coming along to learn, the educators, but also of the medical school and the wider NHS, because this was made available to any NHS colleagues in the west of Scotland. And we also provided automated certification once they completed a certain number. And I'm very grateful to this lady, Jenny Crow, who is one of our learning technologists, and she's also just finishing off a PhD herself. She put this in place, and it was a big challenge because the NHS and the university have different IT systems, and there is a big firewall between them. However, despite the effort that went into this, it hasn't really taken off. It's hard to know why exactly, because those people who have engaged with it have been very positive. But because we only have so much resource ourselves, i.e. time, that we can put into things, we've set this to one side, and we have instead focused more on the parent programme. However, one more recent venture, which actually took place during the pandemic, was this micro-credential. So we were asked by the university to offer a micro-credential and teaching healthcare professionals. And it was myself, together with Claire Taylor, one of my colleagues in the university, who put this together. It's a 10-credit standalone course, but people who do it can, provided they choose to do the assessment, so they can do it not assessed or assessed, and about 50% chose to do the assessment. And if they do the assessment and they meet a certain standard, they can use this as accreditation towards the parent programme. And we have had a couple of students come through this way. What did we learn from the micro-credential? What was our experience? The good parts were that we got funding from the Scottish Government, so they provided funding for us. They also provided a subsidy for learners to come. We had over 300 learners over 2 runs, and that was in the space of about a year and a half. And it was exciting, but it was like quite crazy as well. We worked with an external partner called Future Learn, so it was interesting to find out about their ideas about what the online materials should look like and so on. However, there were some downsides. One was that we developed the course during the first COVID lockdown, and that was, as you will all know very well, a very strange time for everybody. It also meant that we couldn't go out with our video cameras and record people. We had to ask people to record themselves on their phone or on Zoom and send us the recordings, that kind of thing. So that created challenges. There were issues with the interface between Future Learn and the university, and this was important because we had to make sure, because we were having assessment, which could then allow students to actually join our master's programmes, we had to be very careful that we knew about the selection of students coming onto the micro-credential and that the assessment was all properly governed. And I think from my personal point of view, the biggest issue was the significant additional workload, and there was limited academic resource because we only had a bit of Claire's time. So unfortunately, as sometimes does happen with initiatives, including faculty development, even when something is quite successful, without more resource, it can't continue, which is a shame. I've just got a very small number of slides left, but just to say that Yvonne Steiner mentions the importance of research and scholarship into your experience of faculty development. And we put together a publication that you can see here, and that's Camille, my deputy, and me here, and you might like to go and find this later. But this was about our experience of being early adopters in our institution of blended and online learning, so pre-pandemic. And also, just to say that we don't just focus on developing teaching skills. On the master's programme, we also have courses about management skills and leadership skills. And I still deliver workshops, like in-person workshops and research skills for the university or for organisations like ASME. I've done that. They're the Association for the Study of Medical Education. I also mentor colleagues in the scholarship, and that should say teaching and learning, so I've got that the wrong way around. And if you're interested to know what on earth SOTL is, then you can have a wee look at this publication in which I'm a co-author, and that came out a couple of years ago now. So we're almost there. I just want to finish up by thinking about the third ILO, the challenges and debates. Okay, I see that question from Imjad. You're asking about, do we provide scholarships or waivers for low to middle income countries? The college and the university provide some scholarships. You essentially have to Google our website and you will find a page all about different scholarships, but be prepared that they are very competitive. But please do have a look at those. So to go back to the challenges in faculty development, a big thing is faculty time. So the clinical educators who are coming along, they don't have the time to give a lot of attention to their teaching practice skills. And therefore, synchronous sessions are very difficult to organise if you're thinking about online faculty development. And it is a principle with us that we could only offer synchronous sessions that are not compulsory attendance. Even if we record them, we don't make them compulsory. So the compulsory material is all asynchronous. Workload is a big issue. We find on the master's programme that people just do not appreciate the amount of work that it takes to gain a postgraduate certificate, diploma or master's. And that can create issues when you've already got a very busy full-time job. One of the issues we have is with student reps. It's so difficult, we find, as do other online programs, to get people who are willing to do this role. And we think, but we don't really know, we think it's because it's an extra burden on time. And I've already said that that's really precious. There are differences sometimes in the degree of engagement faculty give. That's partly because of competing priorities. So we often get very young doctors who want to build their CVs, and they are wanting to do our programme while they are also doing their clinical exams. And naturally, they put their clinical exams first. And people are motivated by different things. So some people are motivated, some of our students are motivated, it seems, by getting the letters after their names, whereas others are motivated by the learning. They just want to learn, or maybe they want to be a better teacher than their own experience was of in some context as a learner. There are design issues, whether you're thinking about in-person or online faculty development. So for example, do you do didactic presentations, or do you go for interactive sessions? Do you have one-off sessions or a longitudinal programme? And I've told you about some of our experience with those. And always, there are resource issues. There are issues with staffing, with accommodation. One of the reasons that our institution moved to more online provision was the difficulty in providing accommodation for all the courses that we wanted to run. Issues with IT infrastructure, and very often all of these come down to funding. There's no getting away from that. Another important challenge in faculty development, and Yvonne Steinert touches on this, is do we see behaviour change? So if you're familiar with Kirkpatrick's levels of evaluation of an intervention, level 1 is satisfaction of the learners or whomever is receiving the intervention. Level 2 is, does learning take place? Level 3 is behaviour change. we don't measure that. We might assume that if the National Student Survey results are improved, which they are greatly. And then, sorry, I just was slightly distracted there by the chat. But I think that it does say we do need to do research and scholarship into our own faculty development, but there is the issue of research capacity. We're already struggling to deliver the programmes, never mind researching them. And I think there also is an ethics challenge, because if you are significantly involved in the teaching and in the assessment, then there is a power dynamic, even if your students are full-time clinicians and quite senior in their clinical roles. And then just to see debates, excuse me. There are lots of debates, but a couple of them are whether we should have generic or tailored faculty development. You probably got the idea that I think generic has its merits, so we invite healthcare professionals from different professions onto our programme, and we believe that people can learn from other professions, but we do get demand. We get people asking, do we have anything specifically, for example, for family medicine practitioners? And another debate is, what is the best way to do faculty development, in person, online, or blended? And in fact, Professor Shoali and myself met through being on the organising committee of a conference about faculty development, and one of the speakers will be addressing this very issue. And I'm going to unashamedly finish by making a plug for that conference, which is in Glasgow. And I know funding is always an issue. It's not a virtual conference, but if you think that you would like to visit Glasgow at some time in the future, then you might wish to consider coming at this time of the year. That's the end of my talk, but I would very much like to take some questions now. If I can just open the chat. I saw that there were a couple, but first of all, will I ask Professor Shoali, are you happy for me to just answer a couple of the questions in the chat? And shall I stop screen sharing?
Thank you very much, Susan, for the wonderful presentation. Yes, please go ahead. And even our audience can.
Okay, so I stopped screen sharing and I'll try. I saw, so first I'll go to the first one I saw, so excuse me if I've missed any, but and please forgive me if I'm not pronouncing your name correctly, but it looks like Sadie, who said, thank you very much for your kind comment about the presentation. And you said, how did we manage challenges with student evaluation of teaching? The student evaluation of teaching is what led to a lot of the faculty development. I don't know if you want to elaborate on specifically, are you there? Can you unmute? But with student eval, I'll wait to see if you do join in again, but student evaluation of teaching is what we do constantly, I'm sure in common with every other institution, and it was the students' voices that led to, in particular, the implementation of the clinical teaching fellow roles and also the recognition of trainers initiative for the GMC. So is learner driven. Undergraduate students, but also postgraduate medical trainees have delivered an awful lot. They have driven an awful lot of this. We don't have the kind of system that you have in the States. I'm not sure where you're from, but I know in the States, the student evaluation of teaching really can define whether somebody stays on post or not. So we are not quite like that. We do have evaluation constantly, but we take a perspective where it's about enhancing the teaching. So it's teachers do have to respond to students' comments, positive as well as negative. Unfortunately, people tend to give you the negative more, but it's recognised that the response is not always about whether the teaching was good or bad. There are wider issues. I'm not sure if that is what you were hoping to hear me say about that, but by all means add something else in the chat. I think I answered Imjad about the scholarships. Then I've got Mandana who's saying, how do you consider the core contents for the faculty development program. Wow, that's such a difficult question. So first of all, for the CPD program that we ran, we largely, there were two sources. One was the needs of the medical school. So for example, we had to write good quality multiple choice questions, because otherwise our external examiners would not be happy with the quality of our assessments. And therefore it was worthwhile us actually offering faculty development in writing MCQs. But on the other hand, when we had people coming to our workshops, we always included in the evaluation, what would you like to learn about? And if there was an interest, and if there was the ability for us to offer it, if there was somebody with relevant expertise, which there usually was, then we would try to offer something. Regarding the online masters, the way we run that is in the first year is the certificate year, and it is fairly standard material. You will find similar content in all of the masters that are offered, I think, worldwide. And I have seen a lot of the syllabuses, if you like, from the different institutions, because people sometimes come with a postgraduate certificate and then they join our program to do a diploma and masters. So they quite often share with me what they do. And it's essentially teaching, learning and assessment basic principles. So I mentioned earlier the book about understanding medical education. That's the core text that we use. It's edited by Tim Swanick and colleagues. And essentially the contents of that book. However, that book is growing and growing. That always happens with textbooks, and more and more is being added into it. When we look at the second year, we try to cater for people who are interested in more curriculum delivery and management, people who are interested in research, and people who are interested maybe more in teaching in the clinical workplace. So we offer, for example, a course in simulation, that kind of thing. I hope that's answered that question sufficiently, Mandana. Now I'll just move to ask, I see Mohammed, you have your hand up. I hope you're happy with me to call you Mohammed, but would you like to unmute and ask your question?
Thank you very much for your nice presentation. I ask you about training program for faculty about clinical supervisions. To whom you do and how you do it. Thank you very much.
So programs to develop clinical supervisors.
Yes.
Yeah, essentially, well, so this is not an area that I personally deliver, but we have one of our deputies in the medical school, Professor Malcolm Shepherd. He is the person who delivers that. And just essentially, most of our faculty development runs in a similar way. We look at the what is expected of somebody in a particular role, and people discuss what challenges they have with that, and experienced members of staff share how things could be done better, if you like. So, so my colleague delivers that. What I personally deliver is a course in clinical teaching. So it's more about how to do teaching on the ward, essentially, how to use your facilitation skills, how to do just-in-time teaching, that kind of thing. Not quite sure if that is answering your question. One of the things that I can do later is share. We have a page on our medical school website about different opportunities for educators. So there's a page for people who are interested in being clinical supervisors and so on. And that might give you a bit more of an idea about the support we provide for people who are clinical supervisors. So I could send that through Professor Shoali later. So if I can go back to the chat.
Thank you very much.
Thank you for your question. And I can see Tara, who asked, what would I say the best study design for faculty development as educational research? I don't think that there is a best study. I think that it depends on the questions you ask. So I think that if you're trying to understand, say for example, there's an interest just now in the professional identity of faculty developers. When do people begin to feel like, no, so not the identity of faculty developers, sorry, the professional identity of medical educators. When do people begin to feel like a medical educator? What makes them feel like a medical educator? Can they hold the identity of medical educator simultaneously with their clinical identity, or do they merge, or do they have to choose, or whatever? And that kind of research is, at the moment, I think it's very much qualitative, it's exploratory, it's about finding out the experiences of people, so maybe through interviews and focus groups and that kind of thing. If you have two different interventions and you want two different faculty development offerings, and you want to see which one is more effective, then you might be looking at a quasi-experimental design. But essentially, with any kind of education research, it is about the question that you're wanting to ask. There's another, there's a good book, maybe if I can type, I hope I can type in the chat. There's a book, first of all, A Right Understanding Medical Education in the chat, and it's edited by Swanwick et al. And the most recent edition is 2018. And then there's a good book. I say that because I'm the author of a chapter, but it's called Starting Research in Clinical Education, and it's due out this August, so August 2023. And the editors are, I can't remember what the order of them is, but there's Elliot Rees, Alison Ledger, and Kim Walker. So that might not be the right order, but that is aimed at individuals who are doing master's level research. And then the ASME organisation that I mentioned has a book called Researching Medical Education, and it's by Welland and Durning, and they have just issued, I think it's 2023, it might have been the end of 2022, but that's the second edition of that book. I think if you're interested in research, you have to engage with something like that. So thank you for that question. Looking down the list. Okay, so Imjad is saying, do I recommend some, like when you say, do I recommend some blended course or asynchronous standalone course for a medical educationalist early in their career? I presume by that you mean if you are early in your career and you want to engage with development of your teaching skills. I think you engage with what is available to you and see how it works. So if your institution offers in person, I personally like in person. It's nice to meet people, it's nice to talk, and I do like that. And I think now that the pandemic is over, there has been a bit of a move back to a lot of in-person provision. I obviously run an online program and I'm very familiar with it and I'm quite comfortable with it, but a lot of people are still not. But if you find it difficult to access the in-person, either your institution doesn't offer it or it's not at a time that's suitable for you, then online is maybe the way to go. Some courses, some programs will offer mostly online, but they will have maybe a 2-day residential where you can go along and meet your fellow students. We didn't go down that route at Glasgow, just again because of the difficulties with accommodation. That was really the issue for us. So I hope that answers that question. Now I see, is it Malazim? I hope I'm pronouncing that
Professor
correctly.
Bukhari. I am Professor Bukhari. Okay,
Thank you very much, Professor.
First of all, I say you congratulations for such a nice and beautiful lecture.
Thank you.
In the challenges, the last challenge was the behavior changes. How the research can help in changing the behavior in the faculty development?
I think that we don't know how effective things are. We know that, I mean, I have lots and lots of examples of very happy customers, people who say they really enjoyed the faculty development sessions. But did they enjoy it because they got away from the clinic for the day, or they met people and it was a bit more relaxed or whatever? I don't know. And I don't have any direct proof, except for with the facilitator training program. I did, when I was deputy head of the medical school, I did see the student evaluation for their facilitators. So I did get some information, but you have to be careful with ratings, as I'm sure you know, because there are lots of things that students take into account. And sometimes with problem-based learning, they don't necessarily take into account their own responsibility in the learning. So I think that we don't really know if what we're offering is effective. And really behaviour change, I think probably you are looking at better performance of your students or your trainees. The ideal would be if you assume that better performance of your students and trainees translates into what they do in the clinic. That's extremely difficult. That's the Kirkpatrick's level 4. Personally, very, very difficult to do for something that has so many potential variables in it. You know, where you delivered the faculty development, who was in your group when you were working in small group sessions and whatever. So I think that we do have to try and address behaviour change, but it is not easy.
It's not easy.
No, sorry, but
Not
I think
easy.
that if you're, I think that, Yvonne Steinert, I've mentioned her name a lot. She has been calling for this for a long time. She writes on this. Karen Leslie, the chair of the Faculty Development Committee that I was talking about, she also writes. I mean, there are people who do good research on this. I would like to be one of those people, but as I alluded to at the end, it's difficult when you're the person who's constantly delivering it. And I do feel concerned about the ethical issues about researching on my students at the time. So thank you very much for your question.
Okay, I think it is to change the behavior, it's much better to teach them the more ethics, because it is the journey for the long time, not for a short time. Okay, madam, you used another terminology, failing to fail. What does it mean? Failing to fail in the core topics.
Yeah.
What does
yeah.
it mean? Failing to fail?
So we have our students go on clinical placements. I'm sure yours do too, but our students go on clinical placements for 2.5 years at the end of their degree. And each placement is between 5 and 10 weeks long, and they have an educational supervisor who has overall responsibility for the experiences that they have. And the educational supervisor has to give them a rating. And the medical school found that there were some supervisors who had passed students, but when the students went on to the next placement, they were in difficulty, or sometimes we didn't find out until they came to do their clinical exams, their OSCEs, and they would do badly. And when we investigated, we found that, well, maybe there was a supervisor or even more than one who didn't really think that the student was quite good enough, but they didn't want to fail them because they didn't want to be the person who stopped them progressing with their clinical career. And the role we had was really to try and say, you've got to, if they're not meeting the standard, you've got to fail them, because it's in their interest to basically improve, and it's obviously in the patient's interest and colleagues' interest. So is that clear? Okay.
Thank you so much.
You're very welcome. I'm just having a little look in the chat. I'm not quite sure about the comments. Is it? So I'm just reading a comment by Imjad there. When faculty offers some kind of mercy, passing would translate into failing the fail. Yeah, exactly. So essentially, people were trying to be kind by allowing individuals through, but at the end of the day, they are just inviting the student to fail at the clinical exams, or to let down the patient, Imjad. I don't see more questions, so Professor
Okay,
Sean.
can I ask one more question?
Yeah,
Can I
yeah,
ask?
sure.
Okay. Very simple question. What is the difference between assessment and evaluation?
Okay, well, the way we use it in my context is assessment is summative. Well, in fact, it's not always summative. It's about the performance of the learner. So it's about performance of the learner, whereas we use evaluation to be about the teaching program, what is offered to the learner. Okay, Imjad, to see you have your...
Yeah, thank you very much, Professor Jamieson. I was just wondering maybe if I could ask just a question. You mentioned somewhere in your talk, like it was a sustainable assessment or something like that.
Yeah.
That's sounded like a keyword to me. Would you elaborate something on it?
Essentially, it is, thank you very much for your question. Sustainable assessment is really about assessment for lifelong learning. It's assessment that will sustain you as an effective learner. And the people, or the particular person, if you want to read more, there is a person called David Bowd. I've just put his name in the chat. And I think there are key papers by Bowd, and I think it's Solar. I can't, I'm afraid, remember the dates. I think one of them is 2016, but they write about sustainable assessment. But it is things like self-assessment, where you rate yourself against a rubric, and it's to try and develop students or learners' skills in that. And we also reflective assessment, so where you do reflection. But that's the kind of thing I hope that's an answer. It's a short answer, but essentially that's what we aim to do, and also to offer things that are very practical. So the micro-teaching, I said I might come back to that in the Q&A. The micro-teaching is a practical exam or assessment where our students are asked to film themselves teaching or 10 minutes, and they can do it in a lot of different ways. They can have a PowerPoint where they do a voiceover, or they can actually have people who agree to act as their students in a room, and they can just get themselves filmed with their phone. Because what we're interested in is how they construct the lesson and how they engage with their learners. And that they find is very practical, not even so much doing the micro-teaching, but part of the assessment is that they have to peer assess 4 of their peers' presentations, and they have to give feedback. So learning about what other people do, how other people tackle the brief, and also giving the feedback is also something that we aim for. So essentially, I hope that that's an answer to your question sufficient for you to go on and think a bit more about assessment.
Thank you, Susan. I really enjoyed your presentation and the great question and answer part of it. And I think we have to end the session right now, and see you sometime.
That's lovely. Thank you. Thank you all, and thank you for the invitation, and thank you for all the support and reassurance and the questions. Bye.
Thank you so much.
An honor for us. Bye.